First, good afternoon, doctors. Good afternoon, doctors. Today we will be having four reporters on the renal case management on testicular torsion by Dr. Bustamante. And this is your patient. Anesthesia for patient with kidney by Dr. Arroyo. Case management for patient with CDD by Dr. Aguila. Winter and operation by Dr. Abeleda. Maybe not stand for everybody. And then the Father, the Son, and the Holy Spirit. Heavenly Father, we thank you for the gift of today, for the opportunity to again gather this quantity, to share ideas and to learn from our mental stakeholders. We pray for your guidance as we discuss the matters at hand. May it not only enlighten our minds, but also fill our hearts with and believers. We humbly ask and we continue to bless us, that we may fulfill our duties and the service of our patients. May you continue to keep us, our loved ones, and our patients safe. Everything that we do, we offer to you, to bring glory to your name. And this we pray. In the name of the Father, and the Son, and the Holy Spirit.
Good afternoon, doctors. I'm Dr. Bustamante, here to present a case management on urologic emergency testicular torsion. So we have patient BC, a 19-year-old male with main objectives of this case management is to compare different anesthetic plans that can be applied to different populations, on adults and both pediatric populations. Yes. So we have a case of patient BC, a 19-year-old male with no known comorbidities, with unremarkable personal and social history, with no previous anesthetic experience, with a diagnosis of testicular torsion. For a surgical procedure, orchidopexy, possible orchiectomy, right? Orchidopexy left. For the history, 2 weeks prior, patient experienced testicular pain, right? Immediately sought consultant or ER and was advised for surgery. But the patient opted for non-surgical management, which afforded relief. Persistence of symptoms led to consult, hence, and was subsequently admitted. At the time of admission and at the OR, patient had good NPO, no changes in bowel movement, and with flatness. Again, patient has no known comorbidities, has unremarkable personal and social history, with no previous anesthetic experience. Patient was seen at the surgery ER, awake coherent, not in distress, with the following vital signs. 120/90, 98, 19 CPM, a fever of 36.5, and 98% at air. Patient weighs 57 kilos, height of 164 with an allowable blood loss of 1,425. Upon physical examination, we noted a right inguinal mass with a size of 2/3 cm. Patient is classified as 2E, MAL1, environmental distance of 5 to 6, good airway with good neck mobility. For the laboratories, patient has hemoglobin of 166, a hematocrit of 0.45, WBC of 14.5, and platelet of 378. PD-PTT are as follows: 12.8, 30.1%, activity of 87.4, and an INR of 1.1. Patient at the time had clear lungs. For the scrotal ultrasound, there was considerable right testicular torsion, hydrocele left, and varicocele left. So a brief overview of testicular torsion. Testicular torsion is the twisting of the spermatic cord, leading to a decreased blood flow to the testicle, resulting in ischemia, infarction, and potentially tissue necrosis. So for the epidemiology, most common cause of acute scrotal pain. Torsion is present in 3.2% of all children presenting to the ED with scrotal pain. It has a bimodal frequency, peaks in the first year of life and again at puberty. Though there are instances that adults can have these as well. Risk factors are history of cryptorchidism, horizontal testicular lie, and an increased spermatic cord length. So for the pathophysiology, it is an anatomical defect in the tunica vaginalis, allowing the testicle to rotate when the cremasteric muscle contracts. Twisting of the testicle initially causes compromised venous return and can lead to arterial obstruction, ischemia, and tissue necrosis. The testicle can actually rotate from 180 to 720 degrees. The longer duration of torsion increases the risk of tissue necrosis. So within 6 hours, usually surgeons try to salvage around 80 to 100% with a salvage rate of around 80 to 100%, while persistent symptoms of more than 24 hours has a nearly zero salvage rate. So for the anesthetic considerations, for some children and adolescents, still regional anesthesia is sorry. Some of the patients present with scrotal pain. Some does not present with scrotal pain at all. Um, a few studies I've read, ma'am, has yung delayed gastric emptying, nagsusuka po yung first presentation nila to. Yes. JB, sorry. Paano ito? Paano ito tinatanggal? Kasi nakaharap. Sorry. So, for the anesthetic considerations, anesthesia for surgery on the testicles and epididymis can easily be obtained by performing regional anesthesia. Some children and adolescents are occasionally willing to undergo their surgery under regional or regional anesthesia while remaining conscious. If a regional block can provide adequate analgesia, there is no reason to refuse such management, especially for these kinds of surgery which are shorter in duration. Occasionally, this management approach can be considered in children at risk for severe complications during general anesthesia from certain problems such as severe or acute chronic respiratory insufficiencies, emergency conditions with severe metabolic or endocrine disorders, neuromuscular disorders, myasthenia gravis, or some other types of porphyria. Also, some congenital syndromes and skeletal deformities, which can cause cervical instability, we can choose to do regional anesthesia for these kinds of patients. So for regional anesthesia, we commonly use subarachnoid block. This anesthetic plan is chosen because of the short duration of most surgical procedures involving these anatomic structures, the low failure rate of neural blockade, and the avoidance of the sacral nerve root sparing that is usually associated with epidural blockade. A sensory level of T10 is required to block pain's sensory secondary to testicular manipulation. We can give around 10 to 12 milligrams of bupivacaine for these patients. If epidural should be done, we can use lidocaine with epinephrine, which is recommended according to JAPE, to supplement with 5 to 10 ml as needed. Since there can be sacral sparing, we can use supplemental IV sedation with local anesthesia during these kinds of procedures. If surgery is indicated on the testicle or epididymis, then certainly a general anesthetic is always an option. Obviously, this may be one of the only feasible options if the patient refuses to undergo a regional technique for the surgical intervention. We can use standard induction medications and standard maintenance interventions. Usually, muscle relaxation is not imperative, but deeper levels of anesthesia are usually required to obtain autonomic reflexes resulting from intense surgical stimulation that may occur during these procedures. Additional info I've read from the Journal of Urology. For children, even if the child has adequate fasting, good NPO, pain and distress may delay gastric emptying. Thus, rapid sequence induction is indicated in most cases. According to the Journal on Continuing Education in Anesthesia, Volume 10, an LMA is only considered if the anesthetist is confident that there is no risk of aspiration. So for this case, I used subarachnoid block. If I consider long-term downbeating, are there any other signs of abdominal distension? I can consider generalist. Um, so the patient was hooked to standard monitors and nasal cannula. Vital signs were the following. Venophysis was shifted from V5LR to PLR. As per JAFE, 2 milligrams per kilogram per hour of either plain NSS or D5LR can be given. And patient was given an anxiolytic, 1 milligram of midazolam. Yes. Patient was placed in the lateral decubitus position with flexed knees and thighs. Access was palpated, landmarks were noted, and between the L3 and L4 interspace, a septic technique was done. Skin was then infiltrated with 2% lidocaine. Spinal needle, gauge 25, was inserted between L3 and L4 interspace using the midline approach. 12 milligrams of cocaine heavy was given upon observation of the morbotage. Romanche 3 was then achieved after 5 minutes. Patient cannot flex nor move the ano ba? Romanche 13. Yes, sir. Patient tolerated the procedure well with no noted intraoperative events. Patient was then transferred to PAHO, awake, alert, coherent with a stable vital signs. Final diagnosis is testicular torsion right. Procedure is orchiectomy right, orchidopexy left. Total OR duration is 48 minutes with an estimated blood loss of 50 ml. Fluids infused at the time is 400 cc crystalloids, and these are the following post. For the post-operative care for these patients, um, yes, um, usually though, I have read that if in cases of testicular torsion, usually patients, I know the surgeons check both sides po. So bilateral usually yung sine-check nila doon. And then they do orchido pexy on the contralateral side to avoid na par na ma mag-torsion po ulit yung kasi oh, okay. So for the medications, post-operative care, we can give intravenous medications. At the same time, we can do peripheral nerve blocks. So, according to Jaffe, usual medications we give to these kinds of patients, especially if they are adults, are ketorolac around 30 milligrams IM or IV in adults. We can also use, since following orchidopexy, there is usually a high incidence of post-op pain. If the anesthetist is knowledgeable enough, we can do ilioinguinal or iliohypogastric nerve blocks. So I saw this po sa internet. This is a landmark-based approach po on the ilioinguinal and iliohypogastric nerve block. Also, for pediatric cases, since as I have mentioned earlier, usually testicular torsion can happen bimodal peak, so ay sa mga bata po. So we can also use podal blocks. These can be useful especially for post-op pain of patients, of pediatric patients. I have done this only once with the aid of our consultant sa parang orchidopexy case. Yes po. An added information lang. Usually kasi the sacral cornua is at around the age of 8 or 7. So this doesn't usually apply to adult patients, but there are several cases I have read around like the eldest the eldest adult case is around 22 years old po. But it's rare daw for adults. So, ito po yung oral blocks. These are my words. Okay.
So, good afternoon, doctors. I'm David Arroyo. I'm here to present anesthesia for patients with kidney disease, CKD, and stage renal disease, dialysis, and anesthesia for non-renal surgery. Here are my objectives. So, chronic kidney disease is the presence of kidney damage, usually defined as estimated GFR of less than 60 ml per minute per 1.70 meters squared for 3 or more months. In most patients, regardless of the cause, a decrease of GFR less than 25 ml per minute results in ESR. So ESRD refers to the final progression of CKD when renal function is irreversibly impaired and the development of uremia is imminent. So ESRD results in abnormalities of fluid balance and electrolytes with the onset of uremia and oliguria. Expansion of the extracellular fluid volume ensues, presenting with edema, hypertension, signs and symptoms of volume overload. Renal diseases has important implications for fluid and electrolyte management, as well as metabolism of drugs. The cause of renal failure has considerable impact on clinical management. In those patients with renal failure, the timing of their most recent dialysis will determine whether they are hyper or hypovolemic and hyper or hypokalemic. It is important to assess the patient's electrolytes prior to surgery and to ensure that they are euvolemic prior to induction of anesthesia. So here are some causes of chronic kidney diseases, glomerulopathies, tubular interstitial diseases, hereditary diseases, systemic hypertension, renal vascular disease, obstructive neuropathy, and HIV infection. So in complications of CKD include uremic syndrome, renal osteodystrophy, anemia, bleeding, neurologic changes, and cardiovascular changes. So here are the risk factors for perioperative renal failure. Preoperative factors include pre-existing renal insufficiency, advanced age, heart diseases such as congestive heart failure, ischemia, smoking, DM, liver failure, pregnancy-induced hypertension as a physical status of 4 or 5. During intraoperative management, factors include the type of surgery, if it's emergency, intraperitoneal, the thoracic, suprainguinal, vascular, transplant surgery, aortic cross clamping, cardiopulmonary bypass, and inotrope. So for post-operative factors, this includes erythrocyte transfusion, vasoconstrictor use, diuretic use, antidysphosphamide use, sepsis, and nephrotoxins. So for our preoperative assessment, let's check for past medical history for diabetes, hypertension, and other cardiac diseases, social history such as smoking, obesity, and family history of kidney diseases. For laboratories, we need to check ECG, chest X-ray, CBC, electrolytes, BUN, and creatinine. So here are the tests to evaluate the renal function. Can order BUN, KEA, creatinine clearance, urine protein excretion, specific gravity, osmolality, rinse, sodium excretion, and glucosuria. However, there are factors that can influence this interpretation, such as dehydration, variable protein intake, gastrointestinal bleeding, metabolism, advanced age, skeletal muscle mass, accurate timing of urine volume measurement. So in summary, during pre-op evaluation of patients with CKD, this includes consideration of renal function, underlying pathologic processes, and comorbid conditions. Evaluation of the trend in serum creatinine concentration is useful to determine whether renal function is stable. Blood volume status may be estimated by comparing body weight before and after hemodialysis and measuring vital signs with particular attention orthostatic hypotension and tachycardia. Because diabetes is often present in this patient, glucose management is also concerned. Blood pressure should well controlled before elective surgery. Antihypertensive therapy is frequently continued. However, ACE inhibitors are often withheld on the day of surgery to reduce the risk of intra-op hypotension. People may not necessarily want to but around 140. Apo. Sorry. Ah,
And
and so, around 160. 160. 160. Sister, po no, 160. Target pa po is, sorry, no, hindi ko remember kasi. Around 65? Oh, around, I think, 50 to 60. About that. Ah, 65 to 100. Hindi ko po naiintindihan. Sa blood pressure mo, that, wala din si 160 study ko pa ng 160.
cannot say that all would have
Hindi kayo po nabasa about sa map.
Your topic is
CKD and stage renal. So, ano,
boring.
yes po.
Volleyball.
Hindi ko po napansin sa yung range.
Nakachemistry.
Yes po. Yes po.
Hindi natin pwedeng
Okay. Balikan ko po. After the report. So a common recommendation is that the serum potassium concentration should not exceed 5.5 mg per liter on
after tayo dun sa
So the patient should be evaluated predominantly presence of anemia, but the introduction of recombinant human erythropoietin therapy has decreased the number of patients with renal failure for elective surgery with hematoma of less than 30. So during intraoperative management, can book the patient with standard monitors, pulse ox, ECG, temperature, the PCO2, expired oxygen consumption. So during OR, potent volatile anesthetics are useful for controlling intraoperative systemic hypertension and decreasing the doses of muscle relaxants needed for adequate surgical relaxation. Excessive depression of cardiac output is a potential hazard of volatile anesthetics. Decreases in blood flow must be minimized. Avoid jeopardizing oxygen delivery to the patients. Selection of non-depolarizing muscle relaxants for maintenance of skeletal muscle paralysis during surgery is influenced by the clearance mechanism of these drugs. Uh, Mivacurium, Atracurium, and Susantacurium. So renal diseases may slow excretion of Vecuronium and Procuronium, whereas clearance of Mivacurium, Atracurium, and Cisatracurium from plasma is independent of renal function. Opiates are used because they lack cardiodepressant effects and may help minimize the need for volatile anesthetics. Both morphine and heparin undergo metabolism to potential neurotoxic compounds such as morphine p-glucuronide and normeperidine that rely on renal clearance.
Why do they recommend?
Because of their method of elimination, Hoffman elimination. And, Rocuronium relies po sa hepatic and biliary elimination. Patient, that it might have, it will have prolonged effect po on the patient. Longer po effects ng renally excreted meds.
Again,
Uh, Cutoff is 5.5.
patient example of patient eight, three, five. Every
Um, 6 po yung cutoff. So,
needs. Winter.
di po ba?
Asking. But what? So. So. Yeah. So. Hard to.
Six po. Ah. So these are the drugs used in anesthesia practice that depend significantly on renal elimination. We have phenobarbital, thiopental, muscle relaxants, cholinesterase inhibitors, that's endoponium neostigmine, cardiovascular drugs, atropine, digoxin, glycopyrrolate, digelasine, minervinol, antimicrobials, and analgesics such as codeine, meperidine. So patients dependent on hemodialysis require special attention with perioperative fluid management. An absence of renal function narrows the margin of safe between insufficient and excessive fluid administration. Non-invasive operations require replacement of only accessible water loss. A small amount of urine output can be replaced with 0.45% sodium chloride. Um, so this loss is often sorry. So in post-operative management, cautions should be exercised the use of parenteral opioids for post-operative analgesia in view of the potential for exaggerated CNS depression and hypoventilation after administration of even small doses of opioids. Selection of opioids that do not have active metabolites and do not rely on the kidney for excretion is appropriate. NSAIDs are best avoided because they may exacerbate hypertension, precipitate edema, and increase the risk of cardiovascular complications. Continuous ECG monitoring is helpful for detecting cardiac dysrhythmias, such as those related to hyperkalemia. Continuation of supplemental oxygen into the postoperative period is consideration, especially if anemia is present. Um, it is prudent to check levels of electrolytes. Chest radiograph may be useful if pulmonary edema is a concern. Um, yeah. So they are the drug treatment for patients with hyperkalemia. So in giving post-operative management during giving analgesia, we can adjust the dose based on GFR of the patient. Um, some requires increase in interval, decreasing the dose, or some require does not require changing the dose. So here are my references. Hi. Good afternoon po. I'm from Aguila, the second year anesthesia. And I'm here to present case management of CAD patient non-renal solution. Parang same reference kayo ng David. So for the objectives for the family, present a case of patient with CAD solution. This comes to anesthetic management for CAD patients. Pre-operative, intraoperative, and post-operative. To be a summary of anesthetic drugs, lyrics, anesthesia families, that depends to be the present people of financial secrecy, adjustments. So, yes. So, is the case of junior 69-year-old, with a pathologic fracture, primarily tayo secondary renal and service. Status goes to the part of that them. History for my substantial area. CBD stage 5, HD, or total arthroplasty, right? Um, for this treatment is a case of CBD since 2017, complete outreach for 3 times. Um, then 2 months prior to transition, had undergone total arthroplasty. Then they admitted for exclusion due to an accident. Then for total arthroplasty, hence sketching for the surgeon. Um, with unremarkable review systems, for the past medical history, the patient is known to be real within 6.7 million, secondary to and surgery on each week, 3 times a week. Repeat on seven emergency process that and um see since 2020 on the doctor on diet hypertensive since 2040 and I'm not looking at that. Um, the next is for the previous aspect experience, series of IG PAT and APF training on done and API service goes for the testing on last July here at our institution under them. No unexpected complications. For the labs, CBC of 96 sa mga mag-iba paper card sa and hindi pa respond sa activity of 56 P of 79 1.5 48%. Other labs will accept over here for the ECG site and next a remote pass is going up. Patient was reported the alternative of event stress with stable vital signs, weight 50 kilograms and with a BMI of 8 with the allowable for the mark of the thoracic hypostosis and patient at the regular. For the current match, on CP, calcium, permanent, seven, yung family, the renal quality, calcium, and calcium, patients classified as activity in good area. My anesthetic plan is to generalize. Next, we're adjusted. We have those levels of 0.5 25 to 50 meters. Okay. Finally, nabasa. So, yes. Wrong. May then pagpapasok ko ng pagpapasok. Reversal for attack. Attack. Yes. So, this time po ay episode. What is it? So, this is my anesthetic management of for my face. So, for the medicals, given we have doses. So, so again, this is my anesthetic management of so, um, again, for the like pathologic fracture between the right leg, secondary to renal obstructive that's for the arthroplasty left, the secondary obstructive one right standard there and each. For the post-op complications, there should be precautions. Um, sorry. For um, in usual dose is 10 milligrams. So in post-op treatments, you can adjust the dose or the sequence of giving our post-op medications. It depends on the ano pa ba, on the GFR level the patient gives. Ano lang, yung I lifted this table from students. In this table po, drug patients with renal impairment affects most organ systems of the body and um, selecting drugs that do not rely on kidney for excretion is ideal but not always possible. So the first step in should I skip to this slide now? So for my recommendation for the other reduction of We often think that speak for the reality level of the patient, monitoring, like what David has reported. Um, um, nakita ko lang diba, maintain systolic blood pressure of not more than 130, or not less than 130 meter, and maintain back of nasa 90 mount. 1 That's so again for parents with seeking it's it's important to maintain the systolic blood pressure of less than 120. And for post transplantation, it is important to maintain the systolic blood pressure 130. So moving on, because diabetes is often present in seeing patients, glucose management is of concern. Um, blood pressure should well before elective surgeries, and anti-hypertensive therapy is frequently continued. However, um, use it with caution. For example, ACE and ARBs are often withheld on the day of surgery to reduce the risk of intraoperative hypotension. A common recommendation is that serum potassium concentration should not exceed 5.5 equivalents per liter on the day of surgery. But as uh, what the report says earlier, for CP patients or maintain an issue can consider emergency surgeries for a patient having a potassium level of 6. As the 6 equivalents. However, if elective, as long as we can optimize the patient and if can, if the patient is already in dialysis. So, nasa recommendation din po na for CPP patients, chemodialysis prior procedure is recommended. Um, should not exceed 5 yung nasa. So, the patient should also be evaluated preoperatively for the presence of anemia. But should also the maintenance medications of patients. Some are under recombinant human erythropoietin that might help to decrease the number of patients with renal failure to have hematocrit level of less than 0.8 during elective surgeries. For gastric aspiration, prophylaxis, sorry ma'am. Um, um, yung hematocrit, yun, nasa po naman. With the aid of recombinant erythropoietin therapy, there are lesser risks for having elective surgery patients with a hematocrit of 0.3. Yes. For sa stories, mention na dito sa or sa pa-check po kay uh, yung function I bring yung artist but I think um, um, what's for handling low
Basically, because the view is there. And what is in the book to be covered by the government nothing. Down the government.
Um, Not less than 7 million per Sunlight. Less than 9 million.
When like previously for the region where hypergamy. No. We have a certain rate for them. Kaya that rate is low. Down. So like summer food and there um
Um, so, patients maintained on dialysis should undergo dialysis within the 24-hour preceding elective solution. For the um, induction of anesthesia and safety accomplished with most of our IV induction agents like propofol, Tomidin, and Viagra. Um, time and time has volume of by the patients with CTE. Therefore, the function reduction is advanced. Many patients with and speech renal disease response to reduction of anesthesia as typically hypopnea. The likely of hypotension is increased by anemia as well as by anticipation of anti-hypertensives. The indicated rapid sequence induction with oxygen may be performed if the potassium concentration is less than 5.5 decibel. Um, Potassium release following administration of oxygen protein is not exaggerated in patients with CT. Alternative, Alternatively, an depolarizing muscle relaxant, the short onset of action may be selected. Alternative sympathetic nervous system activators. Compensatory peripheral response for small decrease in blood volume, institution of positive pressure ventilation, abrupt changes in body position or drug use, high arterial blood pressure, then result in exaggerated systemic blood pressure. And then um, patients being treated with and or symptoms of experiencing intraoperative hypotension, especially the setting of acute surgical blunders or medical anesthesia. For the maintenance of anesthesia, a balanced understanding technique is the mobilization, muscle relaxant, and offering softening employee. And the definition of volatile anesthetic is not dependent on function. Simultaneously avoided because of concerns related to fluorine and toxicity or production of compound. Although there's no evidence that patients with coexisting renal disease are at least stage of renal dysfunction after administration of COPD. Total IV anesthesia is also an option. Volatile anesthetics are used for operative systemic hypertension and decreasing the doses of muscle relaxant that for anti-surgical relaxing. Excessive depression of cardiac output is a potential hazard of volatile anesthetic. Decreasing blood flow must be minimized to avoid jeopardizing oxygen delivery to the patient. Selection of non-depolarizing muscle relaxant for of skeletal muscle paralysis surgery is influenced by the known clearance mechanism of these drugs. Renal disease is low excretion of fluid, whereas clearances of vacuum and atacule and cis-artacule from plasma is independent of renal function. Renal failure may delay also the clearance of as the principal metabolite attractive and cis-attractive. This might have an effect on the vascular junction, but a high plasma concentration means CNS. For the maintenance of anesthesia, volatile agents are not dependent on genetics. So it is safe to use. May na-mention na din na may compound yung ciboterate that might be uh, that, that depends on renal disease. However, it's evidence that it causes or it contributes to renal impairment. Then for the choice of muscle relaxant, selection of muscle relaxant should uh, should be considered based on their primary excretion. Uh, as like what we discussed earlier, at urine. However, we can uh, we can consider other uh, neuromuscular blocking agents based on our choice and based on our choice and patient to patient or case to case. So for this specific case po, I opted to use opted to sleep slot problem And discuss my for the treatment, for patients with severe renal dysfunction, that requiring dialysis, and those without renal disease undergo complication associated with high incidence of post-operative renal failure, we benefit from pre-operative hydration with balanced solution and uh, a boost of balanced solution restores circulation volume. However, in my case, presented earlier, a patient that is dependent on dialysis requires special attention with respect to the operating fluid management and absence of renal function helps the margin of safety sufficient and excessive to be sense. Um, it had that um, so if um, so, so it's important that the clinical picture of the people, your signs of congestion, edema, hypotony, based from that, you should have an idea of the patient the for total heat for the next month. You should also consider the for this case, ma'am, I opted to use blood products instead of administering these calories from since there um when uh, in this case I use in this specific case ma'am I use ANSM since the patient is not to have the operating and uh, after that I opted uh, in comes to the board. Naka- ano, naka- in- then yes then sorry. Um yes um, for this case man I will more than nasa 0.7 number or yung sa ano ba um, for this man ito yung I will consider condition pang yun na because 0.5 ml per hour. This is not the one people recommend for assessing with ID sorry. See, so again, however, is presented is dependent on realities for selection. With respect to management and absence of the margin of safety, solution, accessibility, and risk. In this case, instead of offering available blood products, and that was easily accounted accounted for each priorities instead of this. Monitoring was also done. 0.7 in this case, I was able to receive enough avoidance of fluid over just for the post-operative management, although is equal neuromuscular located after a muscular agents with anti-anesthesia here. This diagnosis, this diagnosis should consider patients with CP. So basically, we should go happiness even though sorry, since it is also important to check signs of muscle weakness during the real post-op. Other explanation like like the balance that should also consider when muscle weakness persists even after our recently. So it's important to have physical balance even after recently. Concentrate exercise to use of the complex for use of the check for the essentially the CNS preparation. After execution, that's small uses of grades. Administration of facts necessary preparation. Selection of objects that evaluates this appropriately. The use of NSAIDs are less avoided because we excessively excessively hypertension, which increase the risk of cardiovascular complications. For general anesthesia or this case, maybe even for CKD patients. Based on that, then she but then talking India by talking recently. They just mentioned that um payment dysfunction with the effects of receiving deficiencies, chemodialysis was also considered in addition to hypertension, swelling and anesthesia. So it's equal so it's and our that depends. that they are using for other so things to consider uh, should purchase the pros and cons of um, drugs. For this one, this will go result that comes to and drug dosing effects affects most organ systems of the body. And consequently, the pharmacology of drugs for its effects is possible. The first study said with the pediatric milligrams. Since the rate of the drugs is common GFR. If the patient is monitoring the pediatric approximately and primary drug starts with the and after that examination, cellular exposure such as the function. And if the extracellular is contaminated, you should for the patients with dietherapy just for as later processes patients with diabetes and use the dose and parameters. Inside lines and AI this is my leader. Doctors like currently sa Abeleda, pain management, external reason, pain management, patient with chronic kidney disease. So for manager, keep the present as clinical study in pain management, chronic kidney disease, and pleasure means validity and academic our treatment and clinical practice. So for my scenario, with a patient next 80-year-old, diagnosed of CKD stage 5, under dialysis twice a day, and then complaints of generalized pain post hemodialysis. So for my clinical question, how effective non-opioid pain management? So for my population, I use chronic kidney disease, thermal opioids, and outdoor pain management. So using these keywords, I use these keywords in the PubMed, and it revealed one journal, yes, so only one. And then ito, one ko. Kasi kung naglagay ko ng filter ma'am, randomized control tayo. I-review ko one journal entitled Post-hoc analysis of the solar trial indicates that the endothelin receptor antagonist at the same time is associated with chest pain in patients with type 2 diabetes and chronic kidney disease. So for updating the directness, does the study provide enough answer to your clinical question in terms of PIO? The answer would be yes. So for my clinical scenario, our patient is chronic kidney disease. For the journal, it's type 2 DKM and chronic kidney disease. And for the interval, non-opioids, in our journal, it's advanced-and a non-opioid. And for the parasitic placebo, and for the pain management, and for the methodology, it is randomized controlled trial. For the basic validity, was there a clearly defined research question? The answer would be yes. The aim of the study was to demonstrate the implication of endothelin 1 with the endothelin receptor antagonists at the same time reduce the incidence of pain-related adverse events in patients with type 2 diabetes and CKD patients. So basically, the validity for patients, physicians, and are those doing assessments like to the treatment. The answer would be yes. The solar trial was a randomized double-blind placebo-controlled clinical trial conducted on 689 clinical practice sites in 41 countries. Were baseline characteristics similar at the start of the trial? The answer would be yes. The baseline characteristics including both history of neuropathy and some analgesics were balanced between the two groups. Were all patient accounted for its conclusion? The answer would be yes. The analysis was performed on the entire population of 1,834 patients. 1,144 completed the study at the center group, while 1,131 completed on the placebo. What's the precision of the estimate treatment effect reported? The answer would be yes. This table shows the hazard ratio of incident pain-related adverse events by pain categories. Pain adverse events were categorized by higher level through learning blinded manner during the trial. Hazards of musculoskeletal and connective tissues disorders such as headaches and muscle disorder and spinal cord and nerve root disorders were reduced with atrazine. So can the results be applied to my patient? The answer would be yes. Though atrazine can be used with our patient, but atrazine currently is still an investigational drug, and I'm not sure po if it's available currently in our Philippines. So okay, the answer is no po. Okay. Are the likely treatment benefits greater than the potential harm and cost? So the endothelin receptor A antagonist antisental was associated with reduced pain-related events and pain-related use of analgesics needed for these selected patients with type 2 diabetes and CKD. Antisental is currently an investigational drug or investigation on oral receptor antagonist, the development of IgE and IgA and other kidney diseases. So for the discussion, pain is prevalent among patients with diabetes and chronic kidney disease. The management of chronic pain in patients is limited by nephrotoxicity of commonly used drugs including NSAIDs and opioids. Therefore, the therapeutic options for effective pain management in patients with diabetes and CKD are limited. So endothelin-1 or ET1 is a potent endogenous pluripotent peptide produced in response to tissue injury, mechanical stress, hypoxia, and inflammation. Both ET1 and its receptors are widely expressed throughout the body, including the receptors at the peripheral and central pain neuron pathways. Systemic ET1 levels increases in pain, dominated conditions such as musculoskeletal pain and arthritis. ET1 stimulates and sensitizes pain sensation by blocking receptor A and B. So ET1 is also implicated in the progression of CKD. Various clinical trials demonstrated that endogenous receptor antagonists reduce abdominal again. So the study or the solar trial demonstrated that the endogenous receptor A antagonist at the same time reduce the risk of major kidney disease outcomes in patients with type 2 diabetes and CKD. So for the methodology, the solar trial was randomized double-blind placebo-controlled clinical trial conducted on clinical practices in 41 countries. Randomization was performed centrally to an interactive voice response system on the basis of computer-generated random schedule. A stratified randomization scheme was used to ensure balance in the treatment allocation with geographic regions and baseline characteristics. So a total of 3,668 patients were randomized to receive atrasentan and placebo with a double-blind phase and were included in the analysis. In the atrasentan group, 429 patients had at least one pain-related adverse event, yielding in an event of 132 events per 1,000 persons. The equivalent number in placebo was 507, yielding an event rate of 107 events per 1,000 persons. So in conclusion, compared with placebo, atrasentan reduced the risk of all persons of pain-related adverse event. So the endothelin receptor E antagonist atrasentan was associated with reduced pain-related events, pain-related use of analgesics, different selected patients with type 2 diabetes. Dedicated clinical trials are necessary to elucidate and confirm possible benefits of endothelin receptor antagonist treatment of pain management in individuals with CAD. And that's for my last slides. These are my references. 2023 lang, sir. Ano po, phase 3 pa? Yes po. Phase 3 pa. Ano, sir? Yeah.
Yes, ba? Ay, pinapastop na pala ito. Stop share.
Hindi ba to? Hindi ba lang?